Mhm.
All right, so we just want to start by saying thank you all for registering and participating in tonight's Dialogue with Doctors events. This is a really good event. We've done several of these. If you're new here, you're going to learn a lot of information. You're going to be really inspired. And, I say every time you have doctors here who are giving you free advice. You're not paying a copay. They're not filing anything with your insurance. So feel free. Now is the time to ask the questions that you haven't been able to get answered. Ask them now. We have experts here to answer your questions for you. Really, nothing is off limits, but I do want to give everyone a heads up. These aren't doctors who are treating you specifically. So feel free to ask questions in the chat. I'm sure everyone knows how to use Zoom by now, but at the bottom of your screen, it says chat. You can open it up and ask questions there. Don't really get into the weeds into your specific diagnosis, because again, these doctors aren't treating you, but feel free to ask what maybe your treatment options are, because that's what we're here to do tonight. So with that being said, again, thank you all for joining us this evening. Thank you for taking time out of your day. And I want to introduce you to our lovely panelists who have taken time out of their day to really share their insight and expertise with all of us. I'm going to start with Dr. John Lipman. He's an interventional radiologist. Now, we've worked with him before with the White Dress Project, and one thing that we all have said that strikes us most about Dr. Lipman is he has a real passion to acknowledge and take seriously the complaints of his patients. He does not brush them off. There's nothing that's like, oh, well, you'll just deal with it. That'll be fine. He takes it very seriously. And I know a lot of you all who have sought out doctors to figure out what's going on with your bodies might feel like you're being brushed under the rug. We like Dr. Lipman because he does not do that. And he comes up with solutions to really improve your quality of life that are reasonable. And if there's something he's not familiar with, he will direct you to get help. So this is the doctor that I've said before, if I had him my first go round, I would have been in great hands. So let me talk to you about who and what he is and his expertise. He is a renowned authority in the non-surgical treatment of uterine fibroids. He got his master's and medical degrees from Georgetown University here in DC, completed a residency in diagnostic radiology at Brigham and Women's Hospital, Harvard Medical School, then did a fellowship in vascular and interventional radiology at Yale New Haven Hospital, Yale University School of Medicine. He's awarded the highly acclaimed fellowship status in both American College of Radiology and Society of Interventional Radiology. It only honors 10% of radiologists that ever achieved that in their career. He has delivered over 200 lectures to some of the most prestigious centers in the country, including Harvard, Morehouse, Vanderbilt, Yale Medical Centers. He currently serves on the editorial advisory board of Share Care. That is an interactive internet healthcare platform founded by Dr. Mehmet Oz and Jeff Arnold. That's the creator of WebMD. He is the founder and medical director of the Atlanta Fibroid Center, a state-of-the-art facility that specializes in the non-surgical treatment of uterine fibroids and has cared for women from throughout the world. If you go to his Instagram page, he's constantly posting things about fibroids, women's health, and one of the things on his bio, it says, hysterectomy is not the answer for everything. So I encourage you to follow him. Okay, next up, let's talk about Lana Douglas. She is our patient advocate tonight, and she's really had to overcome obstacles from birth. She is the founder and creator of Hope Still Stands. That's a Hebrews 11:1 ministry. Now, when she was born, her parents were told by doctors that she only had one kidney, jaundice, a liver infection, and she also had blood on her stomach. Now, this is at birth. Okay, then starting at age 10, she suffered with horrible periods, pelvic pain that radiated down her legs, the embarrassment of having accidents. We have all been there during that time of the month at school. But again, this is like 10, 11, 12. So you can imagine the embarrassment that she's going through. And then it continued into, when she's working. As a teenager, she always felt that she was having 2 cycles in a span of 3 to 4 days each month. And this is what I'm saying about doctors that don't take you seriously. They are just telling her that she's having bad cramps. Now she knows her body and she's being brushed under the rug. She's now been married to the love of her life, Tim, for over 17 years. During the first 8 years, they really struggled and were unsuccessful in becoming pregnant. She made an appointment to see a reproductive endocrinologist after a series of doctors did not properly diagnose her. Then came the monitoring, the blood work, the infertility drugs, the laparoscopic surgeries. It wasn't until her late 20s, so mind you, this is from 10 years old to late 20s, that finally a doctor told her that she had a double uterus with a double cervix, diagnosed with endometriosis and 3 small fibroids. So then, after 7 years of trying to conceive in a failed IVF attempt, LaDonna was depressed and almost took her own life. So this is a very serious situation. 1 year later, Leanna and her husband became pregnant naturally by the grace of God, and she's been trying to conceive again, been unsuccessful at this point, but she has had a myomectomy and had those 3 fibroids removed and opened up both of her cervixes after suffering with pain for more than a year. So we're going to let her tell her story once we get started. I have 2 more people I want to introduce you to. The third is Dr. Ruth Arumala. Now her thing is this: I have a patient-centered approach to healthcare. I believe in treating people and not their conditions. I have a passion to not only provide excellent medical care, but to empower women to make healthier choices that enable them to live a happier and more fulfilling life. So you can already see where she's coming from. Now, she's a board certified OBGYN with a practice in Mansfield, Texas. She provides evidence-based medical care to women of all ages at all aspects of their lives. She specializes in the medical and surgical management of fibroids, PCOS, sexual dysfunction, pregnancy, and menopause. And in addition to private practice, she serves on the executive board of Texas Health Mansfield. Now, she is very involved in service to her community. She's been awarded for such, and that includes the 2020 National Minority Quality Forum's 40 Under 40 Leaders in Minority Health, the 2020 Patient Preferred OBGYN Menopause Specialist, the 2020 Fort Worth Magazine Top Docs, and 2020 Texas Super Doctors Rising Stars, and 2020 Women in Medicine's Top OBGYN Fort Worth. So clearly she deserves the flowers that she is receiving. She also has a podcast, Pretty Plus Pink Podcast. She discusses everything from fashion to fitness, fibroids, and faith. She interviews inspirational female expert guests who explore a broad range of topics that affect women. And last but not least, I have one more person to introduce you to, and that is Dr. Nicole Williams. She's an OBGYN as well. She has an extensive research background. She was at the National Institutes of Health Research, a grant recipient there in plasmid DNA research during medical school, also presented research on intravenous, I can't even pronounce this, doctor, leiomyomatosis at the University of Chicago. During her training, she earned a certificate in female sexual dysfunction from world-renowned sexual psychologist, Dr. Damina Renshaw at Loyola University, based on the principles of Masters and Johnson. She's also served as representative at the Accreditation Council for Graduate Medical Education Conference, where she presented research on patient safety. She has traveled all over the world, really serving women and dedicated to the welfare of women. That includes the Dominican Republic, Rwanda, Haiti, Cambodia, the Philippines, and Ghana to perform necessary gynecologic surgery. Now, she's been a teacher and a clinical instructor with the University of Illinois at Chicago College of Medicine. She's also served as chairman of the Da Vinci Minimally Invasive Surgery Committee at Mercy Hospital, developing their robotic gynecologic surgery program. And then in 2014, she became only the 2nd physician in the state of Illinois to be certified in the Assessa procedure for fibroids. Now, the White Dress Project is very familiar with the Assessa procedure, so we can't wait to share more about that with you all tonight. Her clinical interests include heavy menstrual periods, fibroids, female sexual dysfunction, menopause, and bioidentical hormone therapy, female incontinence, and overactive bladder treatment. I could go on, but let me just wrap it up with this. Dr. Williams is also a member of Mensa, the International High IQ Society. So that kind of gives you a brief description of the expertise that you all have access to tonight for free and for an hour. So with that being said, let's just dive right in. If you all have any questions, feel free to drop those in the chat. I will get to them when I can. But Dr. Lipman, let's start with you. And I want to start with some of the complaints. I don't want to use the word complaints, some of the concerns that your patients have when they come to see you, and how you handle that and what you've seen and how you were able to treat their ailments.
Well, I see patients suffering with fibroids. I've really dedicated the last 25 years of my career, and I see almost exclusively women suffering with fibroids. So I have a very unique practice. And so every day I see women that have been suffering, many of whom for years, with this problem, because frankly, a lot of doctors that see patients with fibroids kind of dismiss their heavy periods. And so we can talk a lot about that. I mean, I think heavy menstrual periods are a really significant health issue that's not only underappreciated by healthcare professionals, it's also underreported by the women that they serve. And the reasons for this are really multifactorial. I mean, I think, some doctors don't listen to patients. You mentioned about me taking the time. When I see a patient in the office, it's at least 45 minutes to an hour of, physician time. And I'm in solo practice. There are no other providers. Myself, and I've recently added a doctor of nurse practitioner to my practice, but I'm the only physician. And so I can take the time and spend the appropriate time with these patients. And there's a lot of doctors that won't treat heavy periods unless the patient is anemic. In my opinion, if the woman's period is interfering with her quality of life, it needs to be treated, period, pardon the pun. But if it's affecting her quality of life, it needs to be treated. And so, some women don't appreciate the fact that what they're bleeding is abnormal because they've been doing it for so long. Just because it's been going on for a long time does not make it normal. So sometimes the woman's not appreciating the fact that this is abnormal. And so she might also ask her mom, and her mom had fibroids and had a hysterectomy and suffered with heavy periods. So now they think it's this familial thing. Well, we're just heavy bleeders. No, it's abnormal. It needs to be treated. And there are ways, very good ways to treat this. And now we have excellent non-surgical options. You mentioned Accessa. There's an outstanding procedure that I've been doing the last 25 years called uterine fibroid embolization. It treats all the fibroids in the uterus. Doesn't matter if you have 1 or 100. It's completely outpatient, non-surgical. My patients go home the same day with a Band-Aid. That's it, and their uterus. So that's what I see every single day at the Atlanta Fibroid Center.
Dr. Williams, I want to ask you the same thing. When you're treating patients and when you're hearing women's concerns, do you often hear that maybe you're the second or third or fourth doctor they've had to come to see to get the treatment that they know they deserve, but they've, been ignored?
Adriana, you are speaking the truth, because what always gets me is that, so I'm in Chicago, we got 4 million people, and we got a bunch of doctors. We had Northwestern, U of C, Rush University, Loyola. We have 4 major university health systems here. Yeah, I still get patients. I'm in private practice. I work for myself. I work for no man. Although we love Dr. Lipman, all good. But patients have been told by their doctors, oh, it's only 3 centimeters. Oh, it's only bleeding a little bit. Oh, why don't you just take some iron, take ibuprofen, and we'll see you next year. Okay, so then next year, that 3 centimeter fibroid is going to be 4, and she's going to be bleeding a little heavier. Oh, maybe she's had to go to the ER at that time. That's what I'm seeing right now. So when I counsel my patients, because right now I'm a tertiary referral center, so by the time patients get to me, their fibroids are really severe. So what I have been talking to my colleagues, even my residents, because I train residents at 3 different hospitals, let's start treating fibroids like cancer. Early treatment, early detection, early treatment, you're going to get a better outcome. Your fertility levels are going to be better because the fibroids aren't going to be distorting your uterine cavity like they would if we let them sit and sit and sit and sit and sit. Because you might not meet your man until, 30 something. We live in a real world right now. Nobody, we don't always get to meet the dude at 22 and start having kids by the time we're 25. So that has been my thing. And I'm really excited to be on this forum because we actually learn when I'm talking to other colleagues, because, right now I'm teaching residents and I do talk to colleagues, but I love being able to talk to other colleagues from different disciplines and across the nation to kind of see what else is out there and what else that we're doing. So yeah, thanks for having me.
You said two things that I really appreciate. You said we need to treat fibroids like cancer, because people don't realize like 80% of women are walking around with fibroids. And
yes,
it's not something that we
80%
talk
of women
about.
are going to have a fibroid by the time they're 50.
Exactly. And for some reason, we're not talking about it. There's not a lot of research done on it. So it's really just kind of this grassroots effort to get treated and to have doctors like you all who take us seriously and specialize in this. And then the second thing you said was, you come to these forums and you learn too, which just lets me know that you're a doctor who's willing to be open-minded about what your patients are telling you. And again, that is so hard to find. Dr. Lipman, I want you to think on this. I'll come back to you once we get through everybody else, but there's a question right now. It says, I know that many doctors advised against UAE because of the risk of infertility. And so I'll ask you later to talk about your procedure and the risk of infertility.
Right.
Okay, I do want to talk to Dr. Ruth, and I want to ask you the same question. Why is it that you feel fibroids, endometriosis, PCOS, all of these women health issues are so taboo and so quiet, and there's not a lot of research? And I feel like some women say that they go see doctors and they are brushed under the rug, but I feel like other women say that my doctor just wasn't, really knowledgeable about this and didn't know where to help me find the knowledge. What are you finding when you see your patients?
So I think I'm a lot younger in my practice. I finished fellowship in 2018. So a lot of OBGYN training was OB. It just was. And then hysterectomies. And you're trying to get your numbers because you want to finish. And then you finish and you realize that not everybody's pregnant and not everybody has a uterus that needs to come out. And so you start to ask yourself, well, I am fully trained, but I fully don't know anything. And so that got me into a situation where I had to figure out what do I really care about? Do I really care about taking care of pregnant women and churning them out all the time? That's great. It's lovely. Not for me. I take care of pregnant women, but I take care of women that are not pregnant from 13 to death. That's what I take care of. That's what I love taking care of. And so I went out and chose to learn about the most common things. The most common anatomical defect in women's uteruses is fibroids. The most common endocrinology defect in women is PCOS. Everyone goes through menopause. Everyone has a period. So those are things that I decided to learn more about. And I think that is something that, unfortunately, with the type of training that we have, is necessary in order for you to have more answers, right? And so it's like, I am of the same boat as my colleagues in that, I had a patient today, I did a robotic myomectomy on, who said that I'm the 12th doctor she's been to in the last, I think she said 5 or 6 years. And she's been having definitely secondary dysmenorrhea, which is painful periods that are due to something that's anatomical. And she described to me that she would roll around during her periods on the floor. And she knew that her husband was her husband because he would roll with her. And, she described something that are actually the quotes that I talk about, because I had fibroids. I had a myomectomy last year. And I used to feel like the essence of me was leaving my body every period. Like the essence, because I would bleed so heavily that I felt like the essence of who I was was leaving my body every period. And she told me, you know, she said, nobody ever put their hands on my belly. She was 5'5", probably 105 pounds. If you even laid her down, this 20 centimeter uterus would be staring at your face. You didn't even have to put your hands on her. And so I took out 23 fibroids this morning. The largest was 8 centimeters. She's adopted 3 children in the process of trying to have children. Okay. And she's been married for 10 years. She's 33 years old, right? So Dr. Williams talked about how probably 6 or 7 years ago, that was a 3 centimeter fibroid that wasn't doing too much. And somebody was like, oh, whatever. Yeah, it's fine. Everybody got them. You'll be fine. But the thing about it is that as Black women are the biggest non-modifiable risk factor for fibroids is the Black race. And so with that being said, for me, everybody that comes in my office has fibroids until proven otherwise. And I am 90% correct, right? So every ultrasound I put on, when I see a beautiful uterus, even my MA is like, oh, wow. Like, you know, because we're so used to seeing fibroids. So I think that why is this being ignored? I don't know why. I don't know why. I don't know the answer. I think that would be good to know. But I think that the way that our system is set up for our training, at least as OBGYNs, I'm not quite sure how radiology training is. We are inundated with a lot of other things, a lot of other things. And that's why there's subspecialization in medicine, because you have so many other things that you have to get through to get to a stage where you specialize in something. Now, I want to say one last thing. So Dr. Williams talked about being one of the first people to do ASESA. I was the first person to do ASESA in Mansfield, Texas. And I had done ASESA in a different hospital before. But I'll tell you, the process of getting trained was not an issue. The process of getting it through the hospital system, I went to over 17 meetings, 17 that I counted. And after that, I stopped counting. And I had to actually tell a hospital CEO, because he told me, well, if they have fibroids, they have heavy bleeding, just cut off the uterus. And I said to him, I'll just cut off your scrotum. And you see how that works. Well, I'm not quite liked, but I also feel like at some point you have to be almost militant in your approach if you're trying to do something novel for women. And I don't know why at this stage, the treatment options are novel, because so many of us have it.
But you're preaching to the choir, because to say I've been doing UFE for 25 years, yet I see women every single day in my practice who've never been told about it, never heard about it. They've seen multiple gynecologists, only mentioned hysterectomy, never mentioned UFE, not once. And so I've been living that for the past 25 years. So we know very well, about being kind of ignored. And just because we've been doing something for so long doesn't mean it's the right way to do it. And so we've got to start being more thoughtful and more careful about female parts. I mean, as I say, there is no reason whatsoever for a woman to undergo hysterectomy as a first line or an only line treatment. That just shouldn't be done anymore. I think we can all agree on that.
Yeah, I would totally agree. The other thing, especially when it comes to ASESA, what I've heard is that doctors are frustrated with insurance companies because a lot of insurance companies don't cover some of these other procedures. And when we talk about access, it's not just going to a doctor who has the expertise in these various treatment options. That's obstacle number one. Obstacle number one is getting the diagnosis. Obstacle number two is finding a doctor who can treat you and treat you reasonably without taking your uterus. And then, obstacle number three is, how do you pay for it? And so it's all very, tied into the problems of women's health not being given the value that it deserves.
Well, I'll tell you, we're part of involved in legislative issues. UFE has been covered by every insurance company. That's not an issue for UFE because it's been around for so long. It is an issue for Accessa. But interestingly, I'm part of a group that's looking at this. There's a legislative effort in Rhode Island currently. A legislator in Rhode Island is advancing legislation to have insurance companies cover all the options for fibroids, including myomectomy, hysterectomy, and Accessa. Okay, no mention of UFE, and we're supporting the legislation. But we just want her to add UFE. But can you imagine? Accessa has not been around that long, but yet here's this legislation which, with good intentions. We know the legislator that's putting this forward, she had good intentions. She wants everything covered, including Accessa, but she had no idea about UFE. It wasn't told about it. And so it was left off the legislation. I mean, so that, again, this is the kind of thing that, kind of crosses, our disciplines.
Yeah, it's the red tape, it's the bureaucracy, and then it's also the lack of knowledge of things that are out there to treat.
Dr. Lipman, I don't know. I've heard a lot about you in Atlanta, just because I'm really close with Dr. Hawkins. I'm sure you work with her.
Sure.
But in our area, we have Dr. Slonim.
Yep.
And so we work really close with her because there are patients that are not candidates for UFE and there are patients that are not candidates for surgery. And I don't think that, I think that there is some kind of, and I want you to speak on this because I don't know, my like perspective is that there's almost like a competition when there's way too many patients for there to be a competition, right? We have enough patients to go around to take care of any which way they want. I just think that all the options should be discussed all the time. And
Right.
Patients should be given the autonomy to be the CEOs of their health, where they choose where they're gonna go because they have the options. What are your thoughts?
I absolutely agree. I mean, we have a very good collegial relationship with a lot of gynecologists in our area. In fact, I'm friends with Suzanne. Suzanne converses all the time with me and what we're doing. So I've known Suzanne for a long time. In fact, I knew her when she was training at Stanford. I'm a lot older than her, so I can say these things. But we have a great relationship with OBGYNs, and it's a respectful, cooperative effort, which is really important because I bring certain skills to the table with interventional radiology. My gynecology colleagues bring certain surgical skills and other medical skills to the table. Patients benefit the most when everybody brings their skill set to bear on a patient to help them. So we are much better together than in silos. And we do a lot of procedures together. For instance, if somebody, and I presented this data at AAGL a number of years ago, we do this procedure called a combined approach, where if there's a fibroid that's in the cavity, say a 4 centimeter or 5 centimeter fibroid that's a type 0, FIGO type 0 in the cavity, and then she has all these other fibroids with all the symptoms that go with it, how do you treat this patient without surgery? Well, you can with this combined approach. If you embolize the patient, it knocks out all the fibroids, including the one in the cavity. Now, the one in the cavity is going to abort. And so that's what you're worried about, it coming out and her passing this thing. So we do this already in advance. The gynecologist is going to take this out hysteroscopically 2 to 3 weeks after the UFE. It works beautifully. All the fibroids are dead. It's easy to come out. In fact, the gynecologists love those cases. I refer them all the time. They love doing them because it's so easy because the fibroid is dead. And they have a lot of fun with it. So again, it's 2 procedures, but there's no surgery involved, and it's very cooperative, and the patient benefits. It's just a great working relationship.
Lana, I want to jump in here and just ask you, as someone who's been through doctors and who has a story of being misdiagnosed, and it's just so frustrating. Can you tell us, all of the different diagnoses and treatment options that you were told about, the ones that you weren't, and where you are today?
So, especially having a didelphys uterus, which I never heard of until I was diagnosed with it. I just didn't know which way to turn. I just knew that I couldn't get pregnant. And so, trying IVF, that didn't work because I think, when they did the transfer, it didn't go into my cervix. My cervixes are up at 9 o'clock. So if you look at a clock, they're crooked. So on top of that, having the fibroids when they were very, very small, the doctors kept saying, don't worry about the fibroids right now. Let's deal with the endometriosis. Let's open your cervixes. So I kept the fibroids in the back of my mind. So during this year of, being at home, teleworking, sitting at my table, I just started having horrible pains. Those pains I was having years ago, they came back with a vengeance. But it was sitting in the middle of my abdomen. So they said, well, it's probably just a cyst on your ovary. And I'm like, no, this pain, I'm like, I know my body very well. Like what you said earlier, I know my body. And so it's sitting in the middle of my abdomen. I said, it's just a throbbing pain, even during intercourse. I'm trying to fake like everything is okay. And I'm like, no, I'm really like struggling, as I go to work. Actually I was teleworking, but as I go to the store or sit in my car, getting in and out of the car, I would just be in pain. So I went in for a procedure where they put a couple of balloons in both of my uteruses so they can get a good look, which was really, really painful, but I just let them do what they had to do. And then I had to go in for an MRI. And they said, we could give you the option of having a hysterectomy. But my husband and I, we still want to have, at least try to have another baby. So they said, well, the other option is doing a myomectomy. And I never knew that there's non-medical ways of getting rid of fibroids. I didn't know that option wasn't given to me. So in February, I actually had the myomectomy. I'm feeling a lot better. I'm still in some pain, some soreness in my belly button, but I'm hoping for the future that we do get pregnant. But I have that fear, will the fibroids come back? So, but it's just been a long road, a long journey to get to this point, but I'm at peace right now.
Yeah. So, as someone who had fibroids, as someone who used IVF to get pregnant and, had the same concern, I had 10 fibroids removed.
Wow.
And, when you have IVF, this, it's like every day they're in your uterus looking at things. Yeah. And so I did have one come back that was small. My advice is to not let that be the thing that just kind of gnaws at you. Fibroids can come back. One of the biggest mysteries of fibroids is where do they come from? Why do they come? So no one really knows. Mm-hmm. So it's not something that I would dwell on by any means. Mm-hmm. And the benefit again of a situation like tonight where you have these doctors and experts here, now know there are other treatments out there. So you'll be much better prepared should one come back. But, best of luck to you in your pregnancy journey. I'll be praying for you and keeping you in my prayers.
Thank you.
So Dr. Williams, I want to ask you, what are the various treatments, if you could just list off some that you think that people and patients need to, at the very least, be aware of and look into? And when, I know when you see your patients, what is it that you want them to feel comfortable divulging to you, the questions that you want to hear? Tell me about your relationship with the patients.
Okay, so we got two things. So we'll go over what treatment options there are. I'm going to go through them really quickly. Dr. Ruth, Dr. Lipman, please feel free to kind of chime in. So I always start with the least invasive medical type stuff and then go all the way to the other thing. Now I have some patients who walk in and say, take this crap out. And I'm like, absolutely. And I have other patients who just like, just let me know. I kind of want to know what is out there. Because like we already discussed, medicine is still a business, and people, look, even though we know that there's 4 million people in Chicago, so that's 2 million women. And how many OB-GYNs are there? Not 2 million. So there's plenty of business for everybody, but nobody wants to tell everybody outside of the one thing that they can do. But I don't do that because I know that if my patient's happy, she'll come because we do almost everything. And if she wants to get a UAE, fine. So we'll start with regular old medications. I actually start with plain old ibuprofen. It's been around forever. You take it as soon as you see a spot of blood all the way through the period. That should cut the period by about 30%. Next one, tranexamic acid, TXA. The way I tell my patients that it kind of helps the little blood vessels close faster. There's a thing called the clotting cascade, and I say, oh, there's a clotting cascade, but helps the blood vessels close, cuts your bleeding 30, 40%, but it's 3 times a day. You got to take it kind of on time. But these are medications, and both of these are non-hormonal. So we go non-hormonal things, then we go hormonal things. Birth control pill, tried and true, been around. Some people are a little reluctant to take a birth control pill. I do explain to them that birth control and hormone manipulation, the best way to say it, is probably the 3rd greatest invention ever, behind penicillin and aspirin. Birth control. It has freed women from so many things. So I always urge them, just give it a try. I don't want you to stay on this the rest of your life. 3 months, see how you do. My favorite one is Junel or Loestrin. It has norethindrone acetate, beautiful medicine. It works really well. If you don't want to be on birth control, I'm like, okay, that's fine. We got other things. So we already got 3 things already, and we haven't even pulled out a knife. Then once we start thinking about, okay, other medications, there's 2. One's called Orion and the other one is Orlisa. Very similar. I tell my patients it kind of dials down your hormone just a little bit. One side effect is hot flashes, but that's only about 20% of people. So I say, hey, when we're talking about these things, I'm giving you everything, and I give written information. I'm kind of doing this on the fly. I say, this is this, this is this. So then you can go home and you can start Googling, get your phone, figure some stuff out, and then let me know later. So we've gone through a non-hormonal, hormonal, and then, okay, so none of these things are working. Then we got to think about surgery. We got uterine artery embolization. That's Dr. Lipman's specialite. So that just cuts off the little blood supply to the uterus. And I tell my patients, we have 4 blood supplies to the uterus, along with these other little teeny tiny ones that can come from they can come from the intestines. They can come from the omentum, which is this fatty stuff that sits over the intestines. So we got 4. If he blocks off 2, there's still 2 left. And that's why we talk about the numbers with fertility and all that. A lot of doctors, they just don't look up the articles. If you don't look up the articles, then you don't know that there's plenty other blood supply left if that's your thing, if you're just not quite ready to do any kind of surgery, because it's more of a procedural based thing. So that's that. Then we're talking about either Acessa, robotic myomectomy. And these are our 2 minimally invasive options. Robotic myomectomy and or laparoscopic myomectomy, little holes, tiny little holes. And we use teeny little instruments. And then we can either bring the fibroids out through the bottom with the vagina, or we can make a teeny tiny hole about this big, put the fibroid in a plastic bag, bring the little plastic bag up and just kind of remove it at, it can take a while. Yeah, see, Dr. Ruth is like, we be like this. Okay.
That's my
like
whole life.
Yeah. So upper body strength. So that's really not my favorite surgery to do. But we do them because, like I said, I want to be here for the patients. I have a certain skill set. I train minimally invasive in urogynecology. So, let's just get it done. The third one, the other surgery is called Acessa. So I tell my patients this: fibroid, ultrasound. We ultrasound uterus, finding any fibroid. I go, ooh, that's a fibroid. I'm going to measure it. Then I take a big needle like so, goes into the heart of the fibroid, and these smaller needles go out into the fibroid, and then we cook it. It shrinks down about 40% by volume. But in some outlier cases, because I've been doing this since 2013, I've probably done around 500 and something at this point, we'll get about 10% of cases where I'll do like an 8-9 centimeter fibroid, and I'm expecting to get, it'll go down to like 5. But now look, in 3-6 months, it's like 3 centimeters. Whoa, that's awesome. So that's why I advise my patients. I go, look, we have one chance to do a minimally invasive option. We're here for you if we need to go to the next step, which would be an abdominal myomectomy, where we make a little incision way down at the usually lower, like a C-section. if it's a very, very large uterus, if it's up here, right, then sometimes we do have to make a zipper. I try not to make a zipper, and I train my residents, you close your zipper with your hand. You don't put staples in that woman. Do you want staples in you? Exactly. So we sew it up. I tell them, suck it up and sew it up. And that's if we do need to make a bigger abdominal incision. So phew, got them all, I think. Did I miss something?
Yeah, it's a couple.
Oh,
You do. So there is a couple of other options. I do the Sonata procedure also.
oh,
The Sonata is a
I'm
little
just
bit
learning
like
how to do that. Thank you.
yeah.
Thank you.
So Sonata is a little bit like Acessa.
Mhm.
Same idea where you're using a ultrasound and you're injecting in radio frequency energy, just like Acessa. The only difference is the approach is through the vagina, in through the cervix, into the uterus. And so you have no incisions. It's no incision surgery. The problem with that is that Acessa can go up to 8 centimeters. I don't know if you've done any bigger, Dr. Williams, but 8 centimeters is my biggest.
It's as large as I'll go.
And that's what
Sonata is
Dr.
limited,
Lee
isn't
says.
it?
Huh?
It's Sonata a little bit limited with the
Yeah,
size?
5 centimeters is the biggest. So that's one of the problems. You have to have the right candidate, and the location also. I find that sometimes it's easier to get a posterior fibroid from Acessa because you can put in a rectal probe, push the fibroid up, and then you can inject really easily. Whereas with Acessa, you're like trying to get all around. So that's another option. And then they have the MRI guided. I don't know if you do this, Dr. Lipman. I've only seen it done once, but the MRI guided external beams, like ultrasound beams. So
Yes.
it's also myolysis. And okay, so I think Adrianna, you were trying to say in the beginning, but the scientific term for fibroids is leiomyoma. My patients know that because they always see it on I gave them their path report. So they see and they're like, what is this? I have leiomyoma. And so that's the other name is also myoma. So when we're talking about procedures, UAE, the Acessa procedure, Sonata procedure, the ultrasound procedure, and there's actually another one that's a cryo that they use a cold probe. And all of those are all called myolysis. So they all break up the fibroid. They all break up the myoma. So those are all, I put them all in that procedure category because some of them have incisions, some of them don't, but they all just break up the fibroids. They don't take fibroids out. They don't take out the uterus.
Okay, so I'm seeing some questions here in the chat. There's a lot of interest in UAE, UFE. So Dr. Lipman, briefly, someone's asking, are those interchangeable? Are they the same thing?
Yeah,
Yes.
it's
Okay.
exactly the same procedure. It's just sometimes we do uterine artery embolization for adenomyosis, which is a condition that has symptoms just like fibroids, namely heavy periods and pelvic pain. But it's not due to a fibroid, it's due to a condition where the lining cells are actually going into the deeper muscle layer of the uterus. And so it can come in focal forms called an adenomyoma and can mimic a fibroid. And it can be very diffuse, either regionally or even globally thick. In fact, we see a lot of patients that have been diagnosed with fibroids that don't have fibroids at all. Some women have had this diagnosis for years based on office ultrasounds, which mistook someone with an enlarged uterus, and they gave them fibroids because, let's face it, we know that fibroids are particularly disproportionate to African-American women. So if an African-American woman goes into an office with heavy periods, the physician is already biased to fibroids, let's face it. And sometimes, you get this office ultrasound, the uterus is enlarged, she has all the symptoms of a fibroid, you get that label because, the doctor didn't spend enough time talking to the patient, that it wasn't enough, physical exam and so forth. So she gets labeled with a fibroid. And when I get an MRI, I don't use ultrasound. MRI is way better than ultrasound, and they are comparably priced. In the old days, they used to be very different price. MRI much more expensive than ultrasound. Now they're very comparable. So MRI is way better than ultrasound. We pick up all sorts of stuff that we never would see on an ultrasound. And so you can diagnose adenomyosis very effectively. And really, there's only two treatments for adenomyosis that have been shown effective: hysterectomy and embolization. You can't do these other things for adenomyosis, at least not yet. Some people have tried to surgically cut it out, but particularly in the diffuse forms, it's hard to know where you are. You don't have the fibroid is a discrete ball. Has good surgical margins. Adenomyosis is more diffuse, and we've gotten very good results with embolization for adenomyosis. So UAE and UFE are interchangeable. It's also covered by every insurance. We talked about that. It's totally outpatient. It doesn't matter how big or how many. There's a lot of urban myths about fibroids. You talked about the fertility aspect. We've had numerous children born after UFE. I've had multiple sets of twins. Now it's a longer discussion, and I don't want to minimize, it's just saying everybody should get UFE, but we've had lots of children after UFE. It's a longer discussion, and certain patients benefit, I think, from myomectomy the younger you are, and truly the fewer number of fibroids you have. Whereas an older patient, and by older, I don't mean old, but our patients that are going for fertility are usually 35 to 45. Mm-hmm. And so these are older than the 20-somethings. So the older you are, the more numerous. We see patients with 50, 60, numerous fibroids. Myomectomy is going to be challenging to do somebody that has 50 or 60 fibroids, whereas UFE will knock them all out. And so the chance that she will need something else is very small with UFE. I mean, I've seen way too many women that have had 2, 3, I've seen even 5 myomectomies, and now they're coming to me. And so each time you're cutting on that uterus, the fertility is going to diminish. So everybody's got an impact, and you got to look at each patient individually. Certain patients will be better with myomectomy. Certain patients will be better with embolization, and you got to kind of be honest about it.
Yeah, you bring up a really good point, because in terms of my own personal journey, I went to a gynecologist. My uterus was enlarged. Dr. Ruth, I think that you said if you had looked at someone my size and stature, you would have seen an enlarged uterus. And I remember the first doctor I went to got an ultrasound. It was 8 by 10 by 11 centimeter fibroid. And her advice was, if it's not causing you any problems, just leave it there. And so my mom is a doctor. She said, I don't like that. Go to a fertility doctor, because at the time I was maybe 32, 33, and the fertility doctor was like, I don't know why you would ever leave a benign tumor in your body just because. Why would you do that? So she sent me to the doctor who did her fibroid surgery. That doctor, the first thing she did was get an MRI, and I came with like the ultrasounds, and she was like, I don't care, get an MRI. The ultrasound showed 3 fibroids. The MRI showed 6, I believe. She did an open myomectomy. We decided it was best because I had this huge fibroid, 2 medium-sized fibroids. I wanted to get pregnant and have babies. And she's like, my preference is to pull everything out and look at everything closely. She ended up removing 10 fibroids. But she was that doctor who was like, this is what we need to know. Like, we need to know what's going on with you. I don't care if you don't have heavy periods or not. I'm looking at your uterus and it's big. And so she wanted to get it treated. So I believe, Dr. Lipman, that you talked about the infertility, because the people are asking a lot of questions about that. Someone did ask, if estrogen is a cause of fibroids, why is birth control a treatment of fibroids?
So remember, estrogen isn't a direct cause of fibroids. We now know that there are certain genetic components on our DNA, on our chromosomes, when our body's reading these things, that causes us to grow these tumors more than other people. I have a theory about how fibroids grow, is that we do tend to be hardier. And I think our uteri are actually trying to solve a problem. And they grow tumors because they think they have to solve a problem. That is really my theory. So I know that sounds very strange. Now, when it comes, what was your other question that you had, Adrianna?
No, someone was just saying, why would you prescribe birth control?
Why do we prescribe birth control? So estrogen doesn't necessarily cause fibroids. What happens is when we have these swings of estrogen, or if you do happen to have a preponderance, because there are risk factors. Skinny people grow fibroids, heavy people grow fibroids, but if you have other risk factors, and if your tumors are more sensitive, remember, we're treating fibroids like cancer, right? So we do know when they talk about cancer, they talk about how are these tumors going to be responsive? Like you've heard of breast cancer, have estrogen, progesterone, receptor positive, negative, ER, PR. These things are very important for breast cancer survivors. My best educated guess, and of course, they're not going to give us research dollars to figure this out, is that some tumors are more sensitive to hormonal cues than others. I have a fibroid too, but my fibroid has gone from 2.6 to 3.4 in 20 years. I call him Earl because we just don't chill all the rest of the time. But what birth control does, instead of having these big swings, it keeps everything down here. So if you're keeping everything at a steady state, it is less likely that your fibroids, which might happen to be more hormonally responsive, to grow.
One of the things that we do is we try to add exercise and weight loss, because I mean, it seems like estrogen definitely plays a role. We don't know where they come from, but clearly it seems like estrogen has a role. And the reason we think that, a number of reasons, one of the reasons why African-American women disproportionately suffer with fibroids has to do with body fat, and estrogen is stored in fat. And that's, if you look at racially, body fat distribution by race and fibroid incidence, they're very comparable. African-American at the top and Asian at the bottom. Now, we see a lot of women, as you mentioned, with very low body fat and big fibroids. They have a genetic part of it. We can't do anything about picking our parents, but we try to do an anti-estrogen approach. So we try to tell them to limit hormonally rich foods. We try to tell them to eat more fruits and vegetables because they have flavonoids in them, which can block an enzyme that's important for estrogen synthesis. Vitamin D is real important. Only 10% of African-American men or women have adequate vitamin D. We know that vitamin D is a powerful anti-fibroid growth. It's actually a hormone. It actually prevents fibroid growth. Also, green tea extract seems to be very good too. But checking your vitamin D level is really important. It's simple and you can supplement it. And that's a really good strategy. So exercise, lose that excess body fat, eat healthier, and know your vitamin D and get that adequate. You're going to have a very good strategy to try to keep those fibroids at bay. Because I feel like I'm a mechanic. I'd like the patients to keep the right fuel in their car, take their car maintenance seriously. But when it breaks down, you're calling an OBGYN or you're calling me to fix the problem. It would be much better to get it on the preventative side so you wouldn't have to have these challenges.
So I had one other question I saw on the chat was about how are fibroids reabsorbed once they're treated with either Acessa or Sonata. So what happens is we're actually kickstarting the process that we call apoptosis. Now what that happens is the cell is like this, right? And when you heat it, the cell is lysed. That means the cell breaks apart. What happens is after that, water is released for the most part. Your body just takes up the water through normal metabolic processes. So you pee it out, you sweat it out, you don't even notice a difference. Your body is just handling that. Because like we said, once the fibroid is broken up, most of us is water. Your body sucks up that water, fibroids start to shrink. And the nice thing is recovery, 4 days, 5 days, probably with Sonata a little bit less, and you're home and doing your thing. And you won't have to go pee a whole lot, by the way. This is not a thing.
Now, someone is asking, what if you are not a candidate for UFE? Do you then take it to the next level? Well,
almost every single patient that is a candidate for hysterectomy is a candidate for embolization. It's almost everyone is a candidate. And again, these are part of urban myths. Many of the myomectomy patients are also candidates. So there are not many people that are not candidates that are deemed candidates for surgery, either myomectomy or hysterectomy. There are some, and there are some people that we would say, well, you probably will be better served with surgery than embolization, but the vast majority of people that are candidates for surgery are candidates for embolization. And the one other urban myth you talked about, infertility. There are some people out there that believe that if you're interested in fertility, you can't have UFE. As I mentioned, that's a myth. What the concern is, there are some women that have an embolization that will stop menstruating. And if you stop menstruating, you won't be able to have a child, at least the regular way. You could still do IVF and surrogacy, but the chance of that happening is so low. In fact, I've done over 9,000 UFEs. I've never seen it in any woman under the age of 40. As she gets above 40, you start to see it, but 40 to 45 is 1% to 2%. So you have to look at what is the risk of undergoing myomectomy in patients. How many fibroids does she have? Has she ever had a myomectomy? Because in my opinion, if you've ever had a myomectomy, there's really no reason to get a second one, ever, for any reason. Because obviously you're going to set that woman up for a third procedure, likely, because she's got lots of fibroids that are left behind after the first myomectomy. Now you need something like UFE that can address all of the fibroids, not some of them. We tried, one myomectomy, okay, but the second go round really should always be UFE, in my opinion.
So we do have an interesting question. Oh, yeah, go ahead. Go ahead.
Jump in here, Dr. Lipman. I'm sorry, but I'm about to kind of challenge your assertions a little bit.
Good.
Because you can, like, fertility, like the rate of fertility and live births are two different things. And the obstetric concerns are two different things. So I practice both gynecology and obstetrics in very different ratios, but we also have to be quite transparent about the obstetric concerns after myomectomy, after Acessa, after Sonata, and after UFE. There are patients that end up having malpresentation and need C-section. So what did we really save them from? There are patients who end up having miscarriages. There are patients who end up having IUFDs. There are patients who end up having, so for getting pregnant is not the end all. Having a live birth and a healthy pregnancy as an obstetrician is what I'm looking for. And so I actually do Acessa, I do Sonata, but I do not, I tell my patients the risk. I've only done it for a select number of patients who know that they can have obstetric complaints or concerns after a treatment of the fibroid without a removal of the fibroid, because we have to remember that fibroid tissue isn't myometrium. The insertion of the placenta is not the same. So I'm with you. I've read all the studies that I could put my hand on because I want to inform my patients. But I think that talking about the actual incidence of pregnancy and the actual incidence of live birth and taking into consideration obstetric complaints, placenta previa, placenta accreta. I'm the one that has to deal with that too. So we take into concern all of that.
Yeah, well, no, I'm talking about live births. We've had numerous live births, and our births, unlike myomectomy, our births are typically full term and vaginal. So whereas myomectomy, you're probably going to get a C-section. I don't think too many people that had myomectomies are going to be allowed to have a vaginal birth, period. Our births are typically full term and vaginal. And so when you talk about obstetric complications, certainly the early data, and it's showed that there was some slight increase in these obstetrical things you mentioned, like placental things and other of those kinds of things. But what it really, when they looked at it critically, there was a kind of a rush to judgment because people, but when you actually look at the data, the reason why these women had premature rupture of membranes, maybe IUGR, maybe a placental abnormality, it had to do with the woman's age, because a lot of these women were instrumented, they've had multiple procedures previously, and so that in combination with their advanced age was really their risk factor. Because I say, I've had numerous live births, I've had multiple twin births. It's not the concern that we had originally many years ago when there was some concern as there was a slight increased risk of these things, but it just hasn't panned out. It really hasn't. Now, I wish we had better data and I wish we had more research. In fact, I'm very hopeful that HR 2007 that our vice president championed in the Senate and now has the Stephanie Tubbs Jones counterpart by Yvette Clarke in the House of Representatives, hopefully will become law, because that will provide $30 million a year for 5 years to the NIH to study where fibroids come from. They'll also study women of color who've been left largely out of the conversation in something that affects them more than anybody else. That's ridiculous. It'll also provide important, talking about the different options for fibroids. So I'm hopeful that that's going to become law so that we can really get the needed research, because frankly, the fertility research with embolization is really awful. It's just not very good, and we need more data, definitely.
I have a quick question, Dr. Lipman. I've had about 4 or 5 when I was in residency, and since I've been in practice, have had patients either have chronic pelvic pain after, or they've actually had a fibroid. They've had to kind of deliver their fibroid like a baby after having had uterine artery embolization. And when I talk to my patients, and I noticed that you didn't mention that as one of the things that can happen, is especially if a patient, one of the patients I would say who wouldn't be a candidate for uterine artery embolization is a patient who has chronic pelvic pain at baseline. If she might have underlying endometriosis, and my mentor, Dr. Donald Chapman, did a bunch of laparoscopy on women, and he found out, because women were complaining of bleeding and pain, found out that they didn't have PID like they were told. They had endometriosis. And when you have endometriosis, those patients would be ill-served by not having someone take a look, because as we all know, it's not possible to see endometriosis unless it's an endometrioma with any imaging study. So have you seen that?
The MRI really does afford things. Now, yes, you don't see everything. You can't see the endometriosis.
Implants. You cannot see implants.
But you can see the secondary effects of endometriosis. So when they're around the tubes or the ovaries, they cause cysts or endometriomas or dilated tubes. We know that this is likely going to be endometriosis, and it's something.
Right, but you do know that the severity of endometriosis doesn't exactly correlate with the findings that you see on imaging, right?
Well, I think that, you have to look at each
That's
patient.
true.
If you see extra uterine disease of any kind, then likely, something treating the uterus, I can only treat what's in the uterus. If I see a lot of adnexal disease, extra uterine disease, then that patient is not going to be embolized. So we're going to treat patients that have fibroids. Now, are there possible patients that have endometriosis that we're treating that we're not aware of? Possibly, but I can tell you by following the patients, if they don't get better by the 3-month follow-up, if they're not better, then there's got to be a reason why. But fortunately, that's really uncommon. The vast majority of patients at 3 months are transformed. They have their life back. It's women that have been having these gushing, flooding, crime scene-like periods, anemic, lethargic. They're not only physically weak, they're also mentally tired of this month after month.
I'm not talking about bleeding. I'm talking about patients who really aren't candidates. They don't have, yes, they might have heavier periods, but if they have very severe dysmenorrhea, when I say dysmenorrhea to everybody else, that's hella cramps.
Right.
If they have hella cramps, 30% of those patients are going to have endometriosis. I've been doing this for 15 years, and I just keep monitoring. I'm in private practice. I'm not going to publish anything. I don't have the patience or the time, but that's what I've been seeing. And that is why I do advocate, have a look, because I can put a hole about yay big and go, oh, let's just see. And I have gone in patients, and you'll look on my Facebook page, and I have seen patients with just 2 fibroids and some bad cramping, and she have obliteration of her cul-de-sac of Douglas with moderate to severe endometriosis that nobody would ever have seen on anybody's scan. So anyway, with all that, I gotta go. Okay. I'm very sorry. So Adrianna, Dr. Ruth, Dr. Lipman, Liana, I do have to get out of here. I'm so sorry. I told my cousin, and she just had a baby, so I gotta go and,
We'll connect on social.
Okay.
Dr. Williams, thank you so much for your time
Thank
tonight. Certainly
you.
appreciate it.
Appreciate it.
And this is exactly why we have these sorts of conversations and events for everyone, so that you can know your list of options, and you can be as much as you can have that knowledge to take to your doctor.
Exactly.
So Dr. Williams,
Vagina knowledge is vagina power.
Hey, I love it. Thank you, Dr. Williams.
Bye.
Until next time.
Next time.
So, Leanna, I do want to pull you in here because I want to know what your advice would be for women who are having these issues. They go to a doctor. What is the conversation that you wish you would have had? How many, doctors do you wish you would have just said, you know what, you're not it for me, let me go on? What would be your advice to someone who's trying to navigate their problems?
Definitely to use your voice. I know a lot of times, especially when I first began finding out, I was diagnosed with a didelphys uterus and fibroids, endometriosis, and PCOS, which I didn't mention. I was kind of, felt like I didn't know what I was talking about because I didn't feel like I was being listened to. And I felt like I was walking into a new normal because I'm newly diagnosed with all these different symptoms and the way I was born. And I just feel like as women, we need to really advocate for ourselves, find people that will listen to you, look for support groups that will support you. I did not do that because I just didn't think that, I needed it, but I feel like we need to support each other. And as Black women in particular, I feel like our pain is kind of not valid in some people's eyes. I would cry about my pain. I would be, excruciating pain, kneeled over, crunched over at work, at school, in the doctor's office, in the ER, and they would just say, oh, it's just a cyst. Oh, you're just having bad periods. So I feel like we need to be confident when we go into our appointments, not to be afraid. If you need to bring somebody with you, bring someone with you. I know during COVID, it's a little different, but just bring someone with you to kind of encourage you. My husband was very supportive. He went to a lot of my doctor's appointments when we were going through those 8 years of infertility. But I just feel like we just as women need to really speak up for ourselves and search for help.
No, you're absolutely right. And what's so funny is, my husband came to all those appointments with me, and he's been through the whole thing, and he can tell my story as good, if not better than me. You know what I mean? Very tuned in. The other thing that you said was bring someone with you. And one thing through the White Dress Project that we've talked about is, there's another woman who's engaged in it, and we talk on Twitter all the time. And she recently underwent a myomectomy, and she said, when you said X, Y, and Z, that stuck with me. And I took that through my journey. And so the more we talk out loud and we're not silent or shamed or what have you, the better each of us can be equipped with, well, my sister or my friend or my aunt or my cousin, this is what she said, this is her experience. And that brings just like an enlightened conversation that you're having with your doctor. So I agree with you. That buddy system is key. Being open is key. And having a supportive partner is very key, because the emotional wear and tear it can take. I mean, it's a lot. It's a lot. I think for a lot of women, we're so wrapped up in having babies and being nurturers. And, it's our own strength and resilience will be the death of us, because we'll put up with anything. And so I definitely think that we've got to talk about it. We've got to address it, and we've got to know what we can do. We have to know our options. I know, we go into these doctors' offices and they're the experts, so we're deferring to them, but then you don't always get the best advice or the best knowledge. So I totally agree with everything you said. I just want to make sure that I am going through these questions and making sure that we have answered all of them. Dr. Ruth, there was one question that someone asked that said, are any of the medical treatments for fibroids, are they contraindicated for other types of ailments that someone might have? For instance, are there some of the medications, if you're diabetic, maybe you can't take that? Does it work that way?
Yes, and that's why you would need to have your doctor really look at all the options. So if you have fibroids, you do need a dedicated gynecologist. I didn't say OBGYN. I'm an OBGYN, but I didn't say OBGYN. I said gynecologist who is focused and who knows all the treatments for fibroids. And because even if you're not getting your fibroids treated at a certain time, they need to be surveyed. Because one of the things that happens is somebody tells you have 1 centimeter fibroid. On average, fibroids go 0.3 centimeters to 0.7 centimeters a year. If they're growing really fast, you have a risk of it actually being a type of cancer that mimics itself or mimics the way that fibroids look. And that's called a leiomyosarcoma. And that is actually a very aggressive cancer. 1 in 325 women who have fibroids actually have leiomyosarcomas. And so having a surveillance at the basic minimum is what you need, right? So there are loads of medications. Dr. Williams said some of them. I mean, there are other ones. There's a new medication coming out called Myovant. It kind of works like Orlissa in that it turns down the way your brain works. So there's going to be new things coming up because I think that the medical community is coming to a point where we understand that women are no longer just accepting heavy bleeding. We're no longer just accepting, here's birth control, goodbye. We're no longer accepting, oh, you need a hysterectomy when you have a 1 centimeter fibroid. No, we're saying this is what we're willing to do, and we need you to take care of us. And at this point, I think this is a great time to be alive because we have the options, the opportunity to have all these different treatment options.
You know, the other thing I want to ask you, Dr. Ruth, while I have you is, in terms of the medication or the birth control or the non-invasive treatments for fibroids, you know, it's like if you get on a new medication for acne, they tell you to wait 3 to 6 months. Does the same type of thing apply? Like, how long should women be on a medication before they see or feel or notice a difference?
So the easiest way to answer that is 3 cycles. And I say 3 cycles for a reason, because everyone doesn't have monthly cycles. So 3 cycles, I mean, you could have abnormal cycles, right? A normal cycle is 21 days to 35 days if you're an adult, 21 days to 45 days if you're an adolescent. So if you're having monthly cycles, great, we'll find out in 3 months. If you're having longer cycles, we'll find out in those times, right? And whenever you put anyone on any hormonal therapy, you're going to have spotting, you're going to have breakthrough bleeding, and that's going to last for 3 months. And then after that, if I have my patients, every patient that started gets a 3-month visit, because at 3 months, we're going to know whether or not it's working. And we shouldn't wait for a whole year for us to titrate medication, to change medication, to send you to someone else, you know, because there's also level of expertise that I have. And I'm very keenly aware of it. So I have no problem with referring you to someone. The person who did my myomectomy, Dr. Jessica Shepard, is my mentor, right? I can operate really well, but I know there's some patients I've sent to her that I'm like, you're not going to be able to do that. Okay. So I think that the bottom line, if you don't remember anything that I say, remember this: your gynecologist should be your best friend with a bit of knowledge. My patients come into me and we talk about our hair, we talk about everything else, but I have the knowledge too, right? I should care that much about you that I'm willing to send you to whoever I need to send you to get the best care for you. And I should know enough to give you all the options, right? Like, you could go here, you could do this, you could do that. These are going to be the side effects. These are not going to be the side effects. This is the proportion of side effects. That's what I do as a gynecologist. And that's what you need. And if you don't feel that way, find a gynecologist that makes you feel that way. Mm-hmm. There are people that come to me as their 7th opinion. And during COVID, I used to have 7th opinions all the time because everybody did telemedicine. Yeah. Oh, they were getting, there is no problem. You're not married to your gynecologist. You're just not. So
I always say, when it comes to like our hair, we'll go and find someone
You'd
to
be
do
like,
our hair the way we
what's the
like it.
density? What's the this? What's the
Exactly.
that? How long does she get? You look at all the reviews. But you don't do that for
Exactly.
somebody that's gonna swim in your intestines.
Exactly. And that is the key. And if you go to a hairstylist and you don't like what they did, guess what you're going to do? Find a new one. But for whatever reason, with doctors, again, I think it's the intimidation factor. If I'm coming to you for your expertise, whatever you say, you know more than I do, and I accept it. But to your point, Dr. Ruth, you're going to be in my body. No, I'm going to need to feel really comfortable and confident that you're hearing me and you're giving me all of the options, whether you're the expert in them or not. Now, we are very familiar with Dr. Shepherd and we love her to death. So I can appreciate that you are willing to refer her to, refer patients to your mentor. That to me speaks to you as a doctor. I just think that you're spot on. Can you do me a favor, Dr. Ruth, while I still have you? If you don't mind running through the treatment options again and then typing them in the chat so people can refer back or copy and paste it and put it somewhere, just so that they can, look into it further when we're finished.
So I'm going to start off with the least sexy
Invasive.
one, which is least invasive, least sexy, which is just surveillance. You cannot be doing nothing. Surveillance means at least an ultrasound once a year, at least an ultrasound once a year. That's surveillance. I do have patients on surveillance. There are people who, there's some gynecologists in the camp of do not ever survey. And I don't think that's all, Dr. Williams talked about her fibroid hasn't changed in 20 years. So she's surveillance. And then the next option is going with NSAIDs. I prefer naproxen. Naproxen has 30% more efficacy than ibuprofen. It's smaller pill and it's twice a day as opposed to every 8 hours or every 4 hours or every 6 hours. So I prefer naproxen and it's timed. If you track your periods, which every single woman should track their periods, if you track your periods the day before it comes, you start it with food, and that is naproxen. The next option is tranexamic acid. Tranexamic acid is 650 milligrams 3 times a day. That does reduce the bleeding volume. And by virtue of the fact of reducing the bleeding volume, you also reduce the amount of prostaglandins that are released, so you have less pain. There is a pain medication that is specifically used for people with fibroids called mefaminic acid. It can only be used 3 to 5 days a month. And I do use it for my patients with severe secondary dysmenorrhea, which is painful periods that have to do with your fibroids. I do use mefaminic acid for that. So that's not for bleeding, that is for pain. The next option is birth control pills. And you can say to yourself, there's a lot of birth control options. Why do I choose birth control pills? Because it can be titrated. Birth control pills are a misnomer. It's really hormonal pills. And so I can titrate it. I can give it to you 1 in the morning, 1 at night, and I can manage your periods that way. I don't like to do that because birth control pills have a lot of side effects that include nausea, breast tenderness, and weight gain, and mental and mood disorders. We can't walk away from that. And so those are options. There are some patients that get on depot. I don't like to treat fibroids with depot because once you give somebody the injection, I can't take it back. It's 150 milligrams deposited into your body, and it's going to be there. Sometimes it takes 18 months after the one injection for you to ovulate. So if you're trying to conceive, do not ever let anybody put you on depot. The next option would be Orlissa. Orion. I don't use Orlissa. Orlissa is actually endometriosis medication that we were using off-label for fibroids, but the same company, Abbott Pharmaceutical, made Orion. And what's the difference? Orion is Orlissa plus birth control. So it reduces the side effects so it can last, you can use it for a longer period of time. Of course, Orlissa is only FDA approved for 2 years. The next is Olipristal. Olipristal was used as a Plan B. It is a selective progesterone receptor modulator. And it's not used very often in the US because of the risk of liver toxicity. So if anybody ever puts you on it, make sure that you are, because it will be used off label, make sure that your liver function tests are monitored every 6 months. I only have a few patients on it because they're contraindicated to a lot of other things. Then those are the medications. Then we go into procedures. The procedures include uterine artery embolization, or UFE. The way that I counsel my patients are, and I should say this, anything that is not a hysterectomy, 1 in 4 women will need a hysterectomy sometime in their life. That is what the FDA quotes. Because even if we take out your fibroids, the risk of you having recurrent fibroids are anywhere from 10 to 100%. If you are, we have a saying in gynecology that if you are a fibroid, once a fibroid former, always a fibroid former. And that's why Dr. Lipman said that nobody should ever have more than 1 myomectomy, because if you already had 1 myomectomy, clearly we didn't fix it the first time. So we got to cut off the blood supply. So UFE, you have Sonata, which is the hysteroscopic approach. Sorry, let me get some battery. I didn't realize I wasn't charging my computer. And then you have Acessa, which is the laparoscopic approach to the radiofrequency. Give me 1 second, guys. Okay, good. All right, so there are 2, radiofrequency ablation, it actually comes in 3 flavors in gynecology. You have Sonata, which is a transvaginal, transcervical application of the radiofrequency energy. You have Acessa, which is a laparoscopic approach. So you're going to have 2 small incisions and a dot. And then you also have NovaSure. NovaSure is not a great treatment for fibroids. It is a so-so treatment. Radiofrequency is great in general, but NovaSure doesn't work as well for fibroids. It works for any kind of bleeding. So if you have fibroids that distort the cavity, you're not going to get a good treatment using NovaSure, or endometrial ablation using radiofrequency energy. And then you have the surgeries. The surgical procedures are a myomectomy with different routes. There's a hysteroscopic myomectomy that there are no incisions. You go in through the vagina, into the cervix, you resect the fibroids that way. And the drawback to that is sometimes you cannot complete the procedure because your body absorbs too much of the fluid. And if fluid is absorbed, which is salt water, it can change the electrolyte balance in your body, and you can actually get swelling even to your brain. So we have to stop it at a specific point. And so sometimes your procedures are staged. Okay, so we'll do part of it, and then we get to that deficit. We got to stop because we don't want you to get this brain swelling, and then we come back and we finish it. Or it can be laparoscopic, either through the straight laparoscopy or using the robot. I use the robot a lot, and because I don't work in an academic center, so I have to control everything, basically all the arms. And then you can also do an abdominal myomectomy. There is a specific skill called a mini laparotomy. They create small incisions like this. They're actually like gynecologists that only do this type of procedure. It's not laparoscopy, so it's not tiny incisions. It's not an abdominal, but it's a tiny, so I do a combination of them depending on how big the fibroid is, okay? And then there is obviously the hysterectomy. Hysterectomies also come in different flavors. It can either be a vaginal hysterectomy coming out through the vagina. It could be a total abdominal hysterectomy coming out through bigger incisions, either up and down or sideways, or it could be a laparoscopic or even a laparoscopic assisted vaginal hysterectomy. So there are lots of different ways we can do this. So you have a lot of options. Don't ever let anybody tell you that a hysterectomy is your only option. I have said that to patients. But when I tell you that a hysterectomy is your only option, baby, ain't nothing I could put together. I don't have, if I take it, because remember, a myomectomy is the removal of the fibroid and the reconstruction of the uterus. If I have nothing to reconstruct with, ma'am. Yeah. But then also there are sometimes that I have actually sent, and Dr. Lipman, maybe I should start sending people to Atlanta, because I have sent some patients to a interventional radiologist, because I know that's their only option is a hysterectomy, and they'll tell me that they're not a good candidate either. And I can't remember pinpoints to banter with you as to which ones, because I would love to learn more as to what I can and can't send. But hysterectomy is like the very last resort for a very specific group of people.
And I can appreciate that, Dr. Ruth, because, we don't want to say that hysterectomy is not a treatment for some people. It is. And so I can appreciate when you say, I have said that hysterectomy is the only option. If you were my doctor, I would trust you because you've just dropped all kind of knowledge. And so I know that you have looked at my charts and looked at my imaging and looked at me and talked to me, and you've gone through all of this, and I can trust what you're saying because you've not just jumped from 0 to 100 hysterectomy. So I don't want people to think that, hysterectomy is awful or, something
it's not the worst thing in the world. Remember, I don't know if anybody else here has had, I had horrific, I'm talking about horrible acne into my 20s, late 20s, right? And so at one point I didn't have skin. I just had the pimples. And so I saw my dermatologist and I told my dermatologist, I'm sick and tired of this. And she told me Accutane is your answer. She didn't talk about anything else. She said, so there are patients that walk in and they say, I'm sick and tired. I said, give me your uterus. Because that's then. Yeah. Not going to bleed anymore. Yeah. Right. So that is my prescription for, if you're sick and tired of being sick and tired, then that's my option for you.
And if you don't want kids and you're not concerned about fertility, then, it's an easy answer.
Although, can I be the devil's advocate here?
Yes, I would love that.
Because right now, hysterectomy is the second most common surgery done in the United States, which is kind of staggering because half the population doesn't even have a uterus. And the most common reason why we do hysterectomy is for benign disease. If you have uterine cancer, obviously hysterectomy, period, end. But the most common reason why we do it is for these benign tumors, which also disproportionately affect African-American women. And my contention is, I wish everyone was, I wish you represented all the gynecologists because, you obviously went through all the different options, but too many people go right to hysterectomy. I see patients every single day in my office, never heard about anything else. All they get is hysterectomy, and that's got to change because there are these other excellent treatment options. And there's a downside of losing one's uterus. Again, I don't want to be the male talking about the impact of what happens to women when they lose their uterus, but I over the past 25 years, I've counseled women and learned from them. A number of women struggle psychologically, like a man being castrated. There's a lot of sexual dysfunction after hysterectomy, loss of libido, loss of orgasm. We know there's bone loss with hysterectomy. There's urinary leaking. You take this, a lot of our patients have 16, 18, 20 week size uteruses. You take that uterus out, it's going to weaken pelvic floor muscles. You're going to have you're likely to have a urinary leaking issue. There's all sorts of surgical complications from, I see them because if the gynecologist nicks the ureter, the bladder, the bowel, IR is going to be doing a percutaneous drainage or a diversion of urine. So, I mean, I think that we should be very respectful for a woman's uterus, and it should be, if you're going to take it, there better be very good reasons and more than just, I'm sick and tired, because I can fix sick and tired. I can transform sick and tired to normal light periods again, and they can then build up their iron and hemoglobin, and they can literally get their life back with UFE. And so respectfully, I would say, consider UFE more often. And there's ways that we can work together to really improve the quality of people's lives without surgery.
Yeah, and I think, again, this is why we're doing this event, so that everyone has all of the treatment options. They know what to, what if their doctor isn't saying something, then you feel confident to bring it up because you've heard it from experts who have said this is a potential option. And, I totally agree with you, Dr. Lipman. There are certain consequences of every single procedure. So my advice is if you're a patient going to a doctor and they say, we're going to put you on birth control for this, or we're going to put you on a medication for this, or we're going to do UFE, or we're going to do, a myomectomy or a hysterectomy. If they don't say, here's what happens after, then you need to find another doctor. I mean, everything has a consequence. And so if your discussion is a 5-minute thing, a 5-minute diagnosis and solution, you need to move on. If someone is telling you about a medication or a surgery and they're not giving you all of the information, then you need to move on. But I think that everything, every step, every treatment option, there are certain side effects for certain people, and people need to be equipped with the knowledge of those side effects before you and your doctor agree to move forward. So I just want to say thank you all for joining us and sharing your time tonight. I certainly hope that you have learned so much. I hope that you leave here tonight with the confidence that you need the next time you go to your doctor. Even if you are really great friends with your doctor and you've had these discussions, I hope you have the confidence to continue that conversation and continue pressing and pushing and asking for more information, because it is your body. You're the one who has to live with it, and you need to be confident in getting the right information that works best for you. Thank you so much. We did our best to try to keep those treatment options in the chat for you, so copy and paste. We've also been posting the social media accounts of the experts tonight, so follow them because they are giving free advice on Instagram that you're not paying for, and it's good advice. So follow them on social media. And with that, I'm going to turn it over to In Kim.
Thank you, Adrianna, and thank you all so much. This was an extremely insightful discussion, and as you were all talking, I was sitting here thinking about my own situation. You all were talking about the importance of being proactive about your health and not delaying treatment, and I was thinking about how I've delayed my treatment for fibroids for a number of different reasons. And then I thought to myself, how can I truly and effectively advocate for others and empower others and educate others about investing in their health and about being proactive about their health when I'm not doing the same thing for myself? And I also sometimes tend to put my health on the back burner to everything else. And that's why these conversations are so important and so necessary to have on a regular basis, because sometimes we need these reminders to put our health and well-being first and foremost. So thank you all for all of the information that you've provided here tonight. I was empowered, and I know that all who are in attendance have been empowered as well. And to our amazing doctors, Dr. Lipman, Dr. Ruth, Dr. Nicole, thank you not only for your valuable insight and information, but also thank you for your continued support. We truly cannot do this work without the support of our doctors. So I'm so grateful for each of you. And to our fierce patient advocate, La'Anna, you are amazing. Your story is incredibly powerful. It is moving, it is inspiring. Thank you so much for your strength and for your vulnerability. And thank you for giving us all the gift of your story. I always say that when we are liberated from the fear of sharing our stories, it gives the strength and permission for others to do the same. So thank you so much for your willingness to always share yours. And please, please continue to be a light. And to our beloved Adrianna, it goes without saying how much we appreciate you. Thank you tremendously for your support. These discussions are never the same without you, so thank you. And thank you to our friend Nikki, who's behind the scenes. And mostly, thank you to everyone in attendance tonight. We are going to continue having these conversations. We're going to continue having these types of programmings, these types of programs. And we will continue to advocate for you, on behalf of you, and with you. So thank you all And please enjoy the rest of your evening. And I want to also kick it to Tanika to see if she has anything to add to that.
And Kim, that was absolutely wonderful. I'm so proud of you and all the work that you do to curate these events. The White Dress Project would not be where it is and what it is without you. So I just want to give you your flowers in front of everyone because you are amazing. And I'm so happy that you serve on our board. You said everything. Thank you so much to our participants. As the founder of the organization, this is why I started it, because I wanted to ensure that everyone who had a question, everyone who was going through uterine fibroids felt supported and felt that there was a community who understood what they were going through and that they did not have to suffer in silence. So I made a promise to our board and myself to make sure that we have these conversations and bring experts like Dr. Ruthie and Dr. Williams and Dr. Lipman, and always have the patient voice at the table as well. Because without the patient voice, this is not as good as it could be, right? So thank you so much. I don't want to belabor the point, but thank you as always, Adrianna, and thank you so much, and Kim, for the vision that you have every time you put one of these together. If you don't follow us, please do so. Tell a friend to tell a friend to tell a friend. Thank you. Have a great night.
And follow everybody else as well, the people on the panel.
Thanks,
Thank you,
Cynthia.
everyone.